एक जमाना था जब examiners used to ask the questions like, if the person is likely to be suffering from tuberculosis of the spine, what is the investigation of choice? And the answer was MRI. If the person is suffering from a space occupying tumor in the spine, what is the investigation of the choice? It is MRI. But gone are the days where they used to ask these questions now, because the patient is not coming to you with the symptoms. The patient is coming to you with the MRI. And nowadays, the questions are asked by giving you the picture of the MRI of the spine, and then they will ask you what is the diagnosis the patient is probably suffering from. So this is Next Saviors Clinicals. I am Dr. Yusuf Ali Tyagi. Today we are going to have a discussion on the three most important MRI of the spine, which are usually kept for your examination, for your assessment in NEET PG and FMGE exams. So before we come to learn about the MRI of the three important clinical conditions, there are two prerequisites that you should be knowing about. The first one is how to count the vertebrae. You see, most of the time we just assume that this vertebrae is probably the L5 vertebrae, or this vertebrae is probably the S1 vertebrae. You see, it does not run on assumptions. The gold standard way to reach the level of the vertebrae is to count the vertebrae from C2. And that is the only best method to reach the correct level. So remember, counting the vertebrae, particularly by the radiologist, is always achieved from the level of C2, counting the vertebrae down from C2. That means 7 of the cervical vertebrae, 12 of the thoracic vertebrae, 5 of the lumbar vertebrae, and then you have to mark the S1. That is point number 1. Point number 2 is that what are the key sequences in the MRI which are usually kept for you to identify? You see, most of the time it is either T1 weighted sequence and T2 weighted sequence. So how to identify this? First, you have to remember the phrase black and white, which is used for water. You have to look for water that is CSF. If it is black, it is T1 weighted image. If it is white, it is T2 weighted image. Like in this case, if you are looking at the image over here the CSF is appearing white, that means it is T2 weighted image. So hopefully you have understood that these two things are prerequisites before we reach the individual diagnostic conditions. So let's start with the first condition, and that is herniation of the disc. You see, majority of the patients who are coming to the orthopedic OPD are coming with the back pain which is radiating to either of the lower limb, and that is probably because of herniation of the disc. Now, disc herniation, as you can very easily understand, that it is the herniation of the disc, that means outpouching of the disc beyond its normal margin, thereby compressing the contents of the cord, or compressing the roots, or compressing the nerves. So this in itself is the herniation of the disc. Now, what are the different types of the disc herniation? Basically, it is categorized into three classifications. The first classification is that what are the different morphological herniation differences. Like, it could be a disc bulge. How? Imagine if this is a disc, intervertebral disc, and this is the spinal canal. If the intervertebral disc is getting herniated with more than 25% of its outer circumference centrally, then it is called as disc bulge. Simple. Second is protrusion of the disc. Now, how will you identify a disc protrusion? You see, in this case, the disc material is coming out of its content, but the apex is taper in comparison to the base. That means it is having a broader base in comparison to the apex. So this is how the protrusion of the disc is identified. Now, the third one is extrusion of the disc, where exactly opposite is happening to the disc protrusion, where the apex is usually wider compared to the base of the extruded disc. So this is known as disc extrusion. And the fourth one is the disc sequestration. Imagine the disc material is getting separated from the parent disc, then it would be called as disc sequestration. Like in this case, there is a part of the disc which got separated from the parent one and is lying within the spinal canal. So that is disc sequestration. So hopefully you have understood what are the four different morphological features of the disc herniation. If you want to look it in the MRI now this is how the normal disc looks like, where there is a concavity at the level of the spinal canal. But in case of a disc bulge, here we are having a protrusion, that means herniation of the disc into the spinal canal where more than 25% of the diameter is getting bulged. So this is how you will identify a disc bulge. And if we go with the definition, that means it is a circumferential extension of the disc. That means more than 25% of the disc circumference into the spinal canal. Second, if you look at this MRI image, now here what is happening, that if you look at the apex of the disc which has moved out, apex of the disc which has herniated is taper in comparison to the base which is relatively wider. So this is how protrusion of the disc is identified. So if you look at the definition, it is focal herniation with a base wider than the apex. Then if you look at another MRI or another condition here, there is also a herniation of the disc, but in this case, the apex is relatively wider in comparison to the base. And this is known as extrusion of the disc. If you look at the definition of the extrusion, so herniation of the disc with apex wider than the base, then it would be called as disc extrusion. And finally, how on the MRI the sequestration of the disc looks like. In this transverse section, you can very clearly see that this is the part of the disc which has been separated from the parent disc and is lying freely inside the spinal canal. So this is sequestration of the disc. These are the 4 different morphological herniation types of the disc. Now, out of these 4, it seems that the sequestration of the disc is obviously going to have the much more impactful clinical outcomes. It would be extremely painful for the patient, uncomforting for the patient, but the best surgical outcomes are there with the sequestration of the disc, because that sequestrated disc material can easily be popped out, it can easily be removed, and thereby causing decompression of the vertebral column. The results of the surgery which are performed for this sequestrated disc are usually magical for the patient. Now, another classification is a contained disc material or uncontained disc herniation. Now, in case of contained herniation, the posterior longitudinal ligament of the vertebrae, it remains intact. That means the herniation which is covered by intact posterior longitudinal ligament, thereby it is preventing the extreme dislocation of the disc, thereby it is preventing the extreme displacement of the disc into the canal. And the second is that if the posterior longitudinal ligament is getting breached by this disc, then it will result in uncontained herniation because of the prolonged extension of the herniated disc into the canal, thereby compressing the contents of the cord. So that is the second classification. Then finally, the third classification is based upon the location. It is not very difficult, because at the end of the day, as a surgeon, you have to identify that where you have to particularly reach, what is that material which is causing the impingement and thereby leading to the symptoms. Now, if this disc material is getting herniated into the center, it would be called as central herniation of the disc. If it is not exactly in the center but adjacent to the center, it would be called as paracentral disc herniation, which is particularly most common as far as the types of disc herniation based on the location is concerned. Then the third one is where the herniation of the disc material is there into the foramina, thereby compressing the nerve root. It would be called as foraminal compression of the disc. And then finally, if it has moved out beyond the foramina, it would be called as far lateral herniation of the disc. So these are based on the location, which will help a surgeon out to decide that where exactly he has to go for in order to remove that disc material while performing discectomy and decompression of the cord contents. I hope that you have easily understood that how these disc herniations would be identified on the MRI. Now, if you look at these different types of disc herniation based upon the location, now this one, as you can very clearly see, is the centrally compressing the canal, so thereby it could be called as central disc herniation. The second one is not exactly in the center but relatively peripheral to the central, so it will be paracentral, as I told you that out of all the different types of disc herniation, this one is the most common one. Then the third one is where the disc herniation is impinging onto the nerve root, thereby causing compression at the level of the foramen. It will be foraminal disc compression. And finally, the last one where the disc protrusion is beyond the level of the foramen, so it will be far lateral type of the disc herniation. So finally, coming on to the revision, what all we have discussed the types of the disc herniation by three classification systems. The first one is the morphological classification, second one is the containment classification, and the third one is the type of this disc herniation based upon its location. So as what we have studied, the central herniation means herniation in the midline. The paracentral herniation means herniation just lateral to the midline, as we have seen. Foraminal herniation means herniation in the neural foramen, thereby causing the nerve root compression. And extraforaminal, which is far lateral, it is herniation which is even lateral to the foramen. So by this time, you must have understood how to identify the herniation of the disc, if at all the MRI is kept in the question for the purpose of your identification. You know the differences in between extrusion, protrusion, sequestration, the central, paracentral, foraminal, and far lateral. Now, the second reason why the MRI would be kept in your upcoming examination of a spine is the infective spondylodiscitis, particularly the Pott's spine. Now we already know what the Pott's spine is, what is the basic pathology, होता क्या है? In between the two vertebral bodies, the intervertebral discs, they get degenerated because of this infection. Infection होगा तो ये disc material would be getting reduced, so there will be reduction in the disc space. Infection होगा, so first there will be reduction in डिस्क स्पेस. सेकेंड, जब इंफेक्शन होगा तो इंफेक्शन की वजह से देयर इज गोइंग टू बी एन एब्सेस, एंड दैट एब्सेस कुड बी इन फ्रंट ऑफ द वर्टिब्री एंड एडजेसेंट टू द वर्टिब्री, posterior to the vertebrae. Then apart from this, because of continuous inflammatory processes going on, there is going to be a collection of the fluid in and around the vertebrae. So all these three findings are to be identified on the MRI, and it is not very difficult for the purpose. Like if you see in this case, first of all, if you have to identify the plane, then plane is obviously the sagittal plane. Second, what is the sequence of the MRI that you are visualizing? If you look at the CSF, it is appearing white, so it is the T2 weighted image that you are viewing. And the third is the positive finding. Now, if you look at these vertebrae, here the vertebral body is getting degenerated. It is getting eaten away by the organism. Similarly, another vertebral body is also getting disintegrated, and there is a complete reduction of the disc space in between the two. Not only there is a complete reduction of the disc space, there is also a protrusion of these fragments into the posterior column, thereby causing a thecal sac indentation. That means they are compressing the cord also. So once you see this type of degenerative or disintegrative changes along with the thecal sac indentation, thereby compressing the cord, with a long clinical question giving you all the clinical features of the tuberculosis of the spine, then you have got no other option than to mark the answer as Pott's spine. It is a single level spondylodiscitis, thereby causing degenerative changes in the adjacent vertebrae and the intervertebral disc, leading to angular kyphosis and the compression of the cord. So answer is very simple. Just by looking at the MRI image, you can conclude that the image that you are going to visualize is that of Pott's spine. Now, this is one way of asking the question by putting the MRI. The other way of asking the question is to look for the abscess that has moved beyond the margins of those single level spondylodiscitis. How? You know, if there is a Pott's spine, then obviously there is going to be creation of the cold abscess. Now, that cold abscess can move through the psoas muscles and they can prolong their extension. So in this case, as you can very clearly see, that here there is a abscess which is going all along the psoas muscle, particularly on the right side, which is appearing more white because it is the T2 weighted image. How you have identified this to be a T2 weighted image? Because the water in the bladder is appearing white, right? So that is the another way of asking this question in the MRI. And if you particularly focus on the origin of where exactly this psoas abscess is getting created or is getting developed, then here you see the disintegrative changes along with the erosions which are appearing at the level of the vertebral body. Not only this, you can very clearly see the white patches, which is nothing but the inflammatory edema, which is going to also appear white on T2 weighted images, and thereby confirming the diagnosis of tuberculosis of the spine, that means Pott's spine, leading to psoas abscess, that means cold abscess. So these are the only two images that you are likely to get for infective spondylodiscitis, because Pott's spine is such a common condition the patients are suffering from today in our country. So by this time, you probably have identified that how will you mark the answers related to herniation of the disc, if at all, projected in the form of the MRI, and also how will you identify the tuberculosis of the spine, if at all the MRI images are provided to you. Now coming on to the third category, that is tumors in the spine. You see, there are two categories in which the tumors can be asked. One is metastatic tumors, and the second one is the space occupying lesions or space occupying tumors. Now, as you already know, that majority of the tumors which are affecting the spine are metastatic tumors, like the primaries are there in the breast, the primaries are there in the thyroid, the primaries are there in the prostate, and all of them are getting metastasized to involve the vertebral canal. Apart from this, there could be a primary tumor involving the vertebral body, that could be multiple myeloma. But the point is that how will you identify that coupling with the long clinical question? Now, first of all, if you identify this MRI image, which is over here, that whether it is a T1 or T2 sequenced image. So answer for that question obviously is that it is a T1 sequenced image. How have you identified this to be a T1 sequenced image? Because the CSF is appearing dark or the CSF is appearing black. So that is T1 weighted image. Now, wherever there is going to be a tumor, it will invite inflammation and thereby edema. And that inflammatory edematous fluid will also appear black because the water appears black on T1 weighted image. And if you look at the vertebral bodies, then this vertebral body is relatively appearing collapsed because it has lost its density, which is secondary to the metastatic lesion. And second, in its appearance, it is appearing more black because of the inflammation, because of the edema. So this is one finding on the basis of which you can, to some extent, provisionally conclude that the patient could be suffering from a metastatic or a primary tumor of the vertebral body. Another way of knowing about this tumor is to get the T2 or STIR images. Now, how on T2 image would they appear? As you know, that on T2, the water appears white. Now, here in this case, the CSF is appearing white and the edema which is surrounding the tumor is appearing white. So, this is another way of delineating it in a more defined way in comparison to the T1 images. Now, if you further want to attenuate the fat, if you further want to suppress the fat so that it is not a degenerative change, because you know hota kya hai, like most of the metastatic lesions, most of the multiple myelomatous lesions, they are involving the elderly people. Ab elderly people में the fat degeneration also happens. So अगर आपको white tissue दिखाई दे रहा है in the vertebral body, then it could be either because of the fat or could be because of the tumor. So there has to be something which can suppress the fat. तो अगर वो edema की वजह से white दिखाई दे रहा है, then it will become tumor. But अगर वो fat suppress करने के बाद white नहीं दिखाई दे रहा है, then it would be because of the degenerative changes, not primarily because of the tumor. And that is the reason why STIR comes into play. Now, this STIR is responsible for fat suppression. And you know, when you get this fat suppressed, and even then we are having this edematous tissues, then it is going into the favor of a metastatic or a primary tumor of the vertebral body. So this is how you will identify the tumor. You will not make the diagnosis. Obviously, the diagnosis is based on the biopsy, but provisionally you can make the diagnosis that whether the patient is suffering from degenerative changes or is having an infiltrative tissue inside the vertebral bodies. So that is one question to be asked. Second one are the space occupying lesions. You know, spinal cord is existing inside the canal, and in the canal there could be a presence of the tumor. If the tumor is there inside the canal, it may compress the cord or its structures. So these are called as space occupying tumors or space occupying lesions. Now, these space occupying lesions can be of three types. First, as you can very clearly see, that these are extradural. That means outside the dura but within the canal. So these are extradural tumors. And most of the extradural tumors are the metastatic lesions. Majority of the times, these are metastatic lesions. But there is another category. The another category is intradural, dura matter के अंदर है, but extramedullary. That means जो canal and its contents हैं, जो nerves and its contents हैं, उसके बाहर means intradural, extramedullary. So this kind of the second category tumor is intradural and extramedullary. And meningioma or schwannoma are particularly the tumor lying in this category to be identified. Meningioma or schwannoma, although the diagnosis can be made by biopsy or upon biopsy, but these are the two most common tumors which are found in this location, thereby compressing the cord, not they are originating from the cord. And the third category of the tumor is intramedullary tumors. As you can very clearly see that these are lying within the medulla, intramedullary, like astrocytoma, astrocytoma and ependymoma. These are the two tumors which are usually intramedullary in location. Now, the point is that how will you identify them on the MRI? Now, if you look at this carefully, now here we are having the canal. In the canal, this is the nerve. Outside the nerve is the CSF, so it is a T2 weighted image. Now, here there is a space occupying lesion, particularly the tumor. Now, this tumor is actually not expanding the canal. That means the canal is not getting expanded or the nerve site is not getting expanded. The CSF to some extent is obliterated because of the compression, but the canal itself is not getting extended, or there is no fusiform swelling which is usually identified in case of intramedullary tumor. And secondly, on the transverse section at this level, if you can very clearly see that this is the lesion which is compressing the nerve and this is the CSF. So this probably is the intradural but extramedullary tumor because the nerves are not dilated, the nerve structure is not dilated, and second, the nerve structure is getting compressed in its eccentricity. It is marginalized. So this is how the intradural extramedullary tumors are identified both on sagittal as well as transverse images. So let's confirm it further, whatever we have talked about. Now, just by giving you this example on the sagittal image in this case, if you look at this lesion, look at this tumor over here, the nerve root or the nerves are not expanding. There is no fusiform swelling. They are just getting compressed. They are just getting compressed by this tumor, right? They are getting compressed into its periphery. So this probably is the intradural but extramedullary tumor. Now, how the intramedullary tumors are appearing on the sagittal sections, you can very clearly see here the nerve is getting expanded like this. So there is a fusiform dilatation at the level of the tumor. And now it makes sense because if the tumor is getting originated from the nerves itself, so it will lead to expansion of the intramedullary region. So this is how on the sagittal section, both these two tumors can be identified. And this probably is the intramedullary tumor. You will be able to recognize the MRIs on the disc herniations, on the infective spondylodiscitis, and the space occupying lesions or the metastatic tumors. I hope the session was relatively helpful. Thank you very much. All the best for your future endeavors.